Welcome back to the deep dive. Today, we are taking a massive swing at a really key piece of social legislation here in South Africa.
That's right. The Prevention of and Treatment for Substance Abuse Act, Act 70 of 2008.
It's huge. More than just rules, it feels like a national blueprint for tackling substance abuse, doesn't it?
It absolutely is. And it's essential reading, really, for anyone interested in public health, social services, or, the law itself. Our sources show just how ambitious this was.
Trying to consolidate everything.
Into one single coordinated national strategy.
Yeah, and you can see the challenge just in the timeline, can't you? Signed into law 2009?
But only commenced March 2013.
4 years later, that gap. Yeah. It kind of tells a story, doesn't it? About the sheer administrative effort needed to get something like this off the ground.
Exactly. The preamble itself talks about the urgency, the rapid increase in substance abuse. It demanded a uniform national response.
So the act wasn't just about, say, locking people up.
No, not at all. It was a shift, moving toward a modern integrated framework, focusing just as much on reducing demand and reducing harm as on cutting supply.
Okay, so for you listening, the big takeaway right from the start is that this act basically creates a legal duty, a mandate for a complete chain of care.
A full continuum, yes. From a prevention campaign,
Information, education.
all the way through treatment, aftercare, and helping people back into their communities, reintegration.
And it mandates the actual places to provide this.
Yes, the infrastructure. Key aims of the Act are setting up the Central Drug Authority, the CDA, to oversee it all, registering and regulating all the facilities and making sure those services, prevention, early help, treatment, aftercare, are actually available consistently.
Right. Let's unpack that strategy then. Chapter 2, Section 3. It lays out this tripartite intervention strategy, 3 parts.
That's right. That's where the law defines the different fronts in this battle.
So first
is demand reduction. That's about services aimed at discouraging abuse in the first place. Education, awareness about the risks.
Makes sense. Second.
Supply reduction. This is more the traditional side. Law enforcement strategies trying to stop the making and selling of illegal drugs often works alongside other criminal laws, obviously.
Okay. And the third one, harm reduction.
And harm reduction, yes. But this is where the legal text gets quite specific. Really interesting.
Okay, I wanted to ask about that because globally, harm reduction can mean a lot of different things, right? Needle exchanges, safe injection sites, things like that.
No, it can, absolutely. But the sources suggest this act deliberately narrows that scope.
How so?
Well, for the purposes of this act, harm reduction is defined quite tightly. It's limited to the holistic treatment of the person using substances and their family, too.
So it's about managing the fallout.
Exactly. Mitigating the social, psychological, and health impacts of addiction through treatment and rehab. It's not about those broader public health measures you mentioned, which can sometimes be, controversial.
I see. So it's harm reduction specifically tailored for rehabilitation within this legal structure.
Precisely. It's a fundamental distinction. It signals the government's focus at the time, putting resources into recovery centered on dignity within a clinical or community setting.
And that dignity-focused approach, it needs massive coordination, surely.
Oh, absolutely. The Act really stresses that. This integrated approach, combining all 3 strategies, it requires ministers from 20 different government departments to cooperate.
20? Wow.
Yes. It's explicitly required. They have to adopt a multifaceted and integrated approach to implement the National Drug Master Plan. It's not optional.
20 departments. You've got Treasury, Police, Education, Health, Social Development. I mean, that sounds like a huge challenge. How do you coordinate all those different priorities?
That is the core challenge, administratively speaking. But the Act recognizes that substance abuse isn't just a health issue or just a crime issue. It cuts across everything.
You need education for prevention.
Social development for support, Treasury for the funding. The law gives the mandate for them to work together, and the governance structures, which we'll get to, are designed to, force that collaboration.
Okay. And speaking of dignity, Chapter 3 lays out guiding principles for providing services. This must be crucial for people actually using the services or their families.
Absolutely critical. These principles are grounded in human rights. Services have to recognize the whole person, their education, social situation, culture, economic needs, physical health.
Critically.
Critically, the Act demands respect for human dignity and privacy. And it specifically calls for preventing the stigmatization of service users. That's huge.
That really is the philosophical core, isn't it? Shifting from seeing addiction as a moral failing to seeing it as a health and social challenge.
A vital shift. And it goes further. Accessibility is non-negotiable. Services must be available to everyone without discrimination. It specifically mentions vulnerable groups, women, children, older people, people with disabilities. Universal access is the goal.
Okay, let's move from the philosophy to the practical steps. The Act sets out a clear four-part journey for the service user, the continuum of care.
That's in Section 5.2. The first step is prevention. Proactive stuff. Targeting individuals, families, whole communities.
So, information campaign.
Yes, information, communication, education about the risks, but also, interestingly, promoting healthy lifestyles. The Act specifically mentions sports, arts, recreation, building protective factors.
Then comes early intervention, trying to catch problems early.
Exactly. Identifying risky behavior before it becomes full-blown dependency. And looking at the environment, too, things like poverty that might contribute. The aim is quick diversion, interrupting that slide into dependency with support.
Okay, and if prevention and early intervention aren't enough, then comes treatment.
Yes, the core specialized care, providing social, psychological, and medical services together. It's holistic. It includes skills development for getting back to work alongside therapy.
And detoxification.
The Act defines detoxification clearly. It's a medically supervised process managed by a doctor in a proper health facility. It separates that initial medical stabilization from the longer-term rehab.
Right, and the final step, maybe the make or break one, aftercare and reintegration.
Crucial for preventing relapse, yes. This involves things like support groups, building skills to stay sober and independent, and actively reconnecting the person with their family and community. The support doesn't just stop when they leave a center.
Now, what about the places providing these services, the infrastructure? Chapters 5 and 6 deal with this, right? Starting with community-based services.
These are services where the person stays in their community, living at home. But to ensure quality and protect people, the Act insists that all these services must be registered.
Even small local ones?
Yes. It sets a baseline standard of care.
And there are teeth to enforce that.
Oh, yes. Operating an unregistered service is an offense. You could face a fine or even up to 12 months in prison. It shows how seriously the law takes proper oversight.
Okay, what about inpatient places? Treatment centers, halfway houses?
For those, the Act requires the Minister of Social Development to set up and run at least one public treatment center in every province.
One per province, minimum.
Minimum.
Oh.
And every treatment center, public or private, has to employ a multidisciplinary team. You need a social worker, a doctor, a nurse, other mental health professionals. Proper professional expertise is mandatory.
And the oversight here, you mentioned monitoring.
Yes, the monitoring regime is quite strict. Assessment teams can go into facilities to check their meeting standards. And here's the interesting bit. They can enter without notice.
Without notice.
If the team reasonably believes a service user's life is in danger or the facility itself poses a risk, they can walk in immediately. No appointment needed. It's a powerful tool to protect vulnerable people in residential care.
Okay, let's talk governance. How does this Act actually make that coordination happen across those 20 departments? You need a central body.
Absolutely. That's the Central Drug Authority, the CDA. It's established by the Act, Chapter 10.
And its job.
Its core job is overseeing the National Drug Master Plan, making sure those departments actually create and implement their parts of the plan. Facilitating coordination, managing national data, it's the anchor holding it all together.
And its structure reflects that coordination need.
Completely. The CDA's members include representatives from all those 20 government departments, justice, police, health, education, social development, you name it, plus up to 13 outside experts in supply and demand reduction.
So it forces those different sectors around the same table.
That's the design, yes, to compel that high-level dialogue and cooperation.
And does this structure filter down to the ground level?
It does. It gets pushed down to ensure the plan actually gets implemented locally.
How does that work?
At the provincial level, you have provincial substance abuse forums, or PSFs.
Right.
The MEs, the provincial minister, sets these up. Their job is to create the province's own mini drug master plan.
Okay, PSAFs at provincial level and locally.
At the municipal level, you have local drug action committees or LDCs. These are the real grassroots implementers. They bring together local players, police, correctional services staff, health workers, teachers to put the mini drug master plan into action in their specific community.
Right. Now let's get to the sharp end legally. Admission processes. This is key for anyone looking at this from a legal or justice system perspective. There's a big difference between voluntary and involuntary users, isn't there?
A fundamental difference, yes. For voluntary admission, Section 32, it's relatively straightforward. The person applies themselves, or maybe a parent if it's a child. Usually a social worker provides a report on their background.
And getting detox.
A key point. The Director General of Health has a duty to make sure detox services are available at a public health facility for these voluntary users.
Okay. But the involuntary route,
Yeah,
that sounds much more complex. High stakes.
it is. Involuntary admission, Section 33, needs judicial oversight. Starts with someone, often a social worker, maybe a family member or community leader, making a sworn statement to a public prosecutor.
What does the statement need to say?
It's not enough just to say someone is dependent. It has to allege dependency plus something else. Either they're a danger to themselves or others around them, or they're causing serious harm to their family's welfare, or they're committing crimes to feed their habit.
So that statement triggers a court process.
Yes, under Section 35, the magistrate has to hold an inquiry. Crucially, the person has rights.
What kind of rights?
The right to be there, the right to have a lawyer, the right to challenge the evidence, cross-examine witnesses, and give their own side of the story. The magistrate can also order a medical or psychiatric exam to confirm dependency and whether treatment would help.
So it's a proper legal hearing.
Absolutely. It has to be rigorous to protect the person's liberty. Only if the magistrate is satisfied after all that can they order the person to be committed to a treatment center.
Or how long?
Up to 12 months initially. And there's another vital safeguard here. Before sending someone to the long-term rehab center, the magistrate must order detoxification first, either at a health facility or an approved treatment center. Medical stabilization comes before the court-ordered rehab.
That makes sense. And this pathway, it can also interact with the criminal justice system.
Yes, Section 36 allows for that. If someone is convicted of a crime, the court can choose to send them to a treatment center instead, or in addition to a sentence. But if they get jail time too, that sentence has to be suspended.
So it offers a clear diversion route, rehabilitation over punishment, potentially.
Exactly, where it's deemed appropriate.
We should also quickly mention, the Act has specific rules for children, doesn't it? Separate facilities, links to the Children's Act.
Yes, special protections are built in. And there are also mechanisms, Section 44, to transfer people who are already in custody, say in prison or a youth center, into the public treatment system if they're assessed as needing and likely benefiting from that specialized care.
Okay, so if we pull all of this together, this huge, complex act, what's the single most important message for someone listening to this deep dive?
I think the core message is that this act, the 2008 Prevention and Treatment Act, marks a really ambitious attempt by the state to tackle substance abuse as a coordinated public health crisis.
Moving beyond just policing it.
Precisely. Establishing a fully regulated system, from prevention right through to reintegration, all grounded in principles of holistic care and human dignity.
It creates this comprehensive legal framework.
But frameworks need resources to function, don't they? And maybe that leads us to a final thought, something provocative to consider.
Come on.
Well, our sources mention an amendment linked to the National Health Insurance Act, the NHI Act of 2023. It hasn't commenced yet, but it proposes changing how the CDA's work gets funded.
How so?
Instead of relying on money directly allocated by Parliament through votes, Section 7 would be amended. So funding comes from the National Health Insurance Fund.
Ah. Okay, that raises a pretty fundamental question, doesn't it? If the money for this whole system, this dignity-focused holistic treatment network, becomes dependent on the brand new and, let's face it, still developing NHI fund.
What does that mean for the future?
Exactly. How might that shift in funding impact the universal access and the scope of services that the Act promises on paper? It definitely shifts the financial risk, you could say.
It's a powerful question about the future sustainability and delivery of these vital public services, a really important point to watch.
Indeed. And that feels like a perfect place to wrap up our deep dive for today. We hope this has been your shortcut to being well-informed.